A case I had 2 weeks ago at Auckland Hospital just reminded me how important it is whether you're a cardiologist or in general practice and you're seeing patients day for day and things seem much the same. Occasionally things come along that's completely different and a little left field, and it just allows to keep you sort of quite focused on what you're doing. This is a MRI of a patient who presented with 3 days of non-specific chest pain, previously well, and one test after another led to the diagnosis of angiosarcoma of the heart, a malignant vascular sarcomatous tumour in the right atrium, originating from the right atrium, and so one of the rare things that we see, which is a true cancer of the heart. But the reason why I wanted to bring up the slide as the first slide is that that's not what cardio-oncology is. Cancer of the heart does occur, it's rare. We might see a case every couple of years as individual cardiologists, but that's not cardio-oncology. Cardio-oncology is really the interaction between patients who have cancer, the cancer disease, the cancer biology, and the interaction between that and underlying cardiovascular disease, cardiovascular risk factors, and then on top of that, the treatment for that patient's cancer and how all of that leads ultimately to cardiotoxicity. And it's the cardiotoxicity of treatment for cancers that ultimately makes up the field of cardio-oncology. And like most toxicities, there are those that occur acutely during the course of treatment, and there are those that might occur a long time later, potentially years, if not decades, after treatment is completed. And so the link between cardiology and oncology is actually a link that can, in some cases, stay forever. Just a couple of important points and a couple of important concepts to bear in mind. There's approximately 15 million cancer survivors living in the United States today, and that number, of course, will keep increasing. And we know that there's increased cancer survival, and so what the concern is that for those who are able to beat cancer, one doesn't want to then set them up to ultimately develop morbidity or die from cardiac complications courtesy of the treatment for the cancer itself. It almost seems like a fate too cruel for someone to design. And the interaction between cardiology and oncology occurs across all the stages. Before a patient with cancer commences chemotherapy or radiotherapy, they undergo a cardiovascular evaluation, a basic one by the oncologist, to get a feel for whether they have underlying cardiac disease or whether they have risk factors. There's also monitoring, cardiac monitoring during the treatment, and there's also follow-up, cardiac follow-up, once treatment is completed. And so the interaction occurs both at the preventative stage. You might choose to not use a potentially life-saving drug for cancer because of the potential cardiac effects on a patient at high risk. There's also the cardiac interaction when there's early detection of cardiac complications during treatment. And then there's also the management in the late stage. And it's worth remembering that many of the highly effective cancer therapies are cardiotoxic. This is just a list of some of the chemotherapeutic agents that are used for various different cancers, and the named drugs are on the left and the incidence of cardiotoxicity is on the right. And what you can see is, firstly, there's a lot of drugs that are used in chemotherapy these days, and that the incidence of causing cardiac complications is highly variable and different, and ranges from less than 1% for some drugs to nearly 50% for other drugs. And so these issues simply cannot be ignored. If we look about what sorts of cardiac complications can occur, if we start at the top, coronary spasm and ischemia is something that occurs occasionally with some of the drugs and is potentially a real problem, and there's recently been a spate of deaths in patients who died purely due to the side effect of the drug causing severe coronary spasm and ultimately fatal myocardial infarction when the person had no pre-existing cardiac disease. Going down to the left, anti-clockwise, cardiomyopathies, that some of the anthracyclines and Herceptin drugs. Hypertension is becoming a major concern with some of the newer drugs. Various arrhythmias, not just troublesome atrial fibrillation, but ventricular arrhythmias or life-threatening ventricular arrhythmias. Venous and arterial thromboembolism, and also a variety of metabolic and diabetic complications with some of the drugs. And so it's important to understand that when these drugs are being used for chemotherapy, whilst the focus is on curing the cancer, one also has to keep a window open to focus on what sorts of complications might arise and to predict them. Now, separate to chemotherapy is also radiotherapy, and it's not uncommon for patients to receive either radiotherapy in isolation or radiotherapy together with chemotherapy for cancer. But radiotherapy can cause a number of cardiac complications, often many years, if not decades, once the treatment has been completed. And so you're never really outside of the window of risk when that's been done, especially to the chest. And the way radiotherapy interacts with the heart is through valve disease, calcific disease, especially aortic stenosis, atherosclerosis, both symptomatic and asymptomatic, pericardial disease, such as pericardial constriction due to fibrosis of the pericardium, myocardial and endocardial diseases, and also conduction disturbances due to the radiotherapy. And so with that sort of background about chemotherapy, radiotherapy, and the interaction between oncology practice and cardiology, I've got two cases. The first is Roger, who's a 75-year-old male who 4 years ago underwent treatment for lymphoma, which included both chemotherapy and radiotherapy. And as is often the case before that sort of chemotherapy, he underwent an echocardiogram beforehand as a baseline to ensure he had normal cardiac function, which he did. And after treating his lymphoma successfully, the hematologist discharged the patient with a comment written there, "I have not arranged further follow-up, and thanks for monitoring for cardiac side effects." Now, this is a real case, and the question that I would have is, well, why, and what on earth does that actually mean? I think it's a little bit unfair, personally. So just let's think about a couple of concepts for that particular patient. The first question you ask yourself is understand the nature of the patient's cancer. What did he have? He had lymphoma, and the lymphoma is considered by the hematologist to be cured. Understand the specific treatment and the specific agents used for that patient. And in this case, it was an anthracycline-based chemotherapy, amongst other agents, and the patient received radiotherapy. Thirdly, what cardiac side effects might you anticipate based on what we've just understood? Well, firstly, left ventricular dysfunction, either asymptomatic or symptomatic heart failure. But because of the radiotherapy, you really are looking across the entire spectrum. Valvular, coronary, myocardial, pericardial are all game for this patient at some point later on in their life. These effects could occur early, or these effects might occur late. The patient may present to you with symptoms of them, but you also may be obliged to do some screening for high-risk asymptomatic patients. The next question would be, well, what sort of screening would you need to do, and what modality would you use? And this particular patient who had both anthracycline-based chemotherapy and radiotherapy, you really are looking at a constellation of evaluation, including an echocardiogram to cover the myocardial dysfunction and the valve dysfunction. You're looking at ECGs to look for the presence of any conduction system disturbance. You're looking at treadmill testing or other forms of stress testing because this person's at increased risk for coronary disease courtesy of the radiotherapy. And in terms of the frequency and the modality of screening, well, that's where you do get off the hook, because I don't think that's something that you need to do, but you would need to understand that this patient should be referred to a cardiologist or to a cardiac team to consider all those sorts of issues, to do as a minimum a baseline echo and treadmill test, and then to take into account what might need to be done at a later date if those tests were reassuring. This is just an example of oncology protocols. They have on a protocol for almost everything, and it's quite daunting to actually see it. But this just gives you some indication as to what we would need to look at when we decide what sort of echo or what sort of testing would need to be done, not just when the patient's having anthracycline, because that's the hematologist's role, but subsequently. And near the bottom of that slide is what to do 6 months after treatment, 1 year after treatment, every couple of years after treatment. And so there are protocols that exist for each of the chemotherapeutic agents that give us some indication as what we need to do and when we need to do it. Now, the second case is different. This is a woman who had some valvular disease due to rheumatic fever, and she then subsequently developed breast cancer, had a mastectomy, underwent chemotherapy with an anthracycline again, and now presents with recurrent disease and is receiving treatment with Herceptin. And with the Herceptin therapy, she had 4 cycles uneventfully, and now starts to see you complaining of breathlessness, waking up at night short of breath. And the question is, what steps should you take now? And so if we go back to the slide that I showed you a few minutes ago and ask the same questions, except this time we'll put in different answers. So understand the nature of the patient's cancer. This patient has had breast cancer. understand the specific treatment. In this case, it was an anthracycline-based chemotherapy and it was Herceptin. There was no radiotherapy used. What cardiac side effects may you anticipate? And in this particular case, it's really just one. It's left ventricular dysfunction or heart failure. Neither of those drugs have any risk with regards to arrhythmias or coronary artery disease or valve disease. These drugs cause left ventricular dysfunction and heart failure. What screening would you need to do? Well, from an investigation perspective, you're looking at echocardiography, and the main sort of tool that we use is left ventricular ejection fraction, but you may also see some reports using something called left ventricular strain, which is something which is used as a more sensitive tool, whereby if you have early left ventricular dysfunction, your strain numbers will be reduced and your ejection fraction could still be maintained. And so you have a potential to pick up early impairment before the ejection fraction actually reduces. And the next question is, well, how often would you need to do this echocardiogram? And so this person did have an echo. You were very suspicious for heart failure. She had typical symptoms for it, and the echocardiogram showed a left ventricular ejection fraction of 35%, which is quite significant impairment. And in addition, she's got symptoms of heart failure. And so normally what would happen in this instance is that the oncologist would usually give myself or one of my colleagues a call. We would commence the patient on standard heart failure therapy, but they would also need to ask, well, what do we do with the Herceptin? And that's when things do get just a little bit tricky, because Herceptin is being used to improve this patient's life expectancy, and now you're getting a very serious cardiac complication. So in this particular case, 2 cardiotoxic drugs were used, not just one, and not surprisingly, the patient has developed cardiac dysfunction. That's defined as a drop in an EF of more than or equal to 5% if the patient is symptomatic, or more than or equal to 10% if they're asymptomatic, to a level less than 53%. And so this patient easily fulfills the diagnosis of cardiac dysfunction secondary to the 2 agents. But you have to also understand that there were 2 different drugs given, and they're actually both quite different. The anthracyclines typically cause type 1 dysfunction, which means that it's irreversible, and it's typically dose dependent. And if you look at the myocardium, there are ultrastructural changes that will typically occur when high doses have been used in the past. And this can occur either early or, in this case, late. And so the worry with the anthracycline type of LV impairment is that you may not get full improvement because you've got true ultrastructural irreversible changes to the myocardium. And that's in contrast to the Herceptin, which was the second agent the patient received, where the impairment is typically reversible. There aren't any structural changes, permanent changes in the myocardium, and it's also not dose dependent. It's very idiosyncratic. And so it's very difficult, if not impossible, to tease out quite which one is causing most of the harm. And you need to balance that up with the fact that if you stop the Herceptin, which this particular algorithm tells you need to do, the patient is very aware now that the drug that's been spoken about so positively as being a potential game changer is now suddenly being withheld, while a second unexpected diagnosis has come into the fore with an uncertain long-term future. And so it's a very difficult situation, and we do see this quite commonly. And so in terms of what do you do, well, there is this sort of protocol about what you do, and what we would normally do in summary is we have to withhold the Herceptin with that degree of heart failure. You would very aggressively treat with medication, and I really do try to interact with the GP in these sort of cases in terms of getting them onto low-dose ACE and beta blocker therapy, and to make sure that you see them regularly to up-titrate to the maximum tolerated dose. You don't just get them on a small little dose and wish them well for 2 to 4 to 6 weeks. This is very time sensitive, because the aim is to get them to an EF close enough to normal and asymptomatic to give you the opportunity to discuss reintroducing Herceptin, which may very well cause problems as well. And so you don't want to consider reintroducing it if you've barely made any improvement in the EF. And you're not going to get an improvement in EF necessarily just with withholding the Herceptin, because they've also got anthracycline on board that might have caused permanent damage. So in terms of cardio-oncology, well, what does the future hold? And so if you look on the right, these are 5-year survival rates for the usual sort of cancers that we're all accustomed to. Some of them have very, very dismal survival rates no matter what you do. The colour from blue, red to green is in the 1970s, the 80s, and then the beginning of 2000s. And you can see in green that no matter which cancer you're talking about, patients are surviving cancer more so than what they did in the past, and that clearly is a positive thing. But there's also an explosion now of new chemotherapeutic agents that are allowing these patients to live longer. And with these new agents coming with improved prognosis is also new and unexpected toxicities, which we have to be aware of. And this is a list of some of the drugs which I really do struggle to pronounce, let alone spell, but I've come to understand that these are the ones that cause hypertension. And not just a bit of hypertension, can cause quite severe hypertension. If you look on the far right, stage 3 or 4 hypertension could be between 10 and 12% of patients on this drug, and any grade of hypertension could be as high as 20 to 40%. And these are people without hypertension and often young patients. And so you've really got to be on the lookout for these sorts of side effects actively, not just passively, and manage them, because otherwise you have a scenario where you've saved the patient from their oncology and they've died subsequently from cardiology. And so my final slide really is, I think, a very, very nice example of a balancing act where you want to give the patient all that can be offered with chemotherapy and radiotherapy to improve prognosis, but you have to anticipate, preempt any anticipated cardiac complications, aggressively treat early, liaise very closely with the oncologist and between us and the GP to try and tilt the balance in favour of the patient. Thank you.
Thank you, Ivor. Very good presentation. During it, I was doing a little bit of a groan, which you wouldn't have heard. It was inaudible, but I was thinking of you general practitioners out there. And so what was your response to this talk? I mean, well, with more and more people surviving cancer on all manner of these chemotherapeutic agents, and more things to look out for. Can you keep up with this expanding workload that you have to do? Would anybody like to say anything about that?
Euthanasia is an option. Don't go through it.
Right? Is that a generally held opinion? Ivor, what's your feeling about all this? Because, I mean, there you are, you're at the cutting edge, and you're treating the cardiac complications. Are there special clinics that you think should be set up for this? I mean, how is all this translated to the general practitioner?
So, I mean, even before we get to the level of the general practitioner, there are there's an expanding field of cardio-oncology.
Yep, you want this.
And there's, thanks, Ted. There's an expanding field of cardio-oncology. There's a subspecialty now around the world in some centres where a person can be called a cardio-oncologist, and that just is testament to the fact that really there's such a complexity with all of this that it's just very difficult to imagine how everybody in general practice could understand and keep up with all of this sort of thing. And so I've somehow got drawn into this and I've been happy to do so, but it requires quite close liaison with an oncologist. They soon know and work out, like a dog when they know they're going for a walk, who will take them. The oncologists soon work out who's going to be on their side for this patient's journey. And it just requires very careful communication between the oncologist, the cardiologist and the GP. But as long as you liaise carefully and you talk about these sorts of things, then the GP doesn't have to worry about being the leader of all of this, but they do have to be very aware that whilst cardiology and oncology will lead it, you are going to be part of all of this as well. I mean, the reality is, statistically, many of us in this room are going to have to deal with this not as professionals, but potentially as patients. And so it's not going away. And so, like a lot of challenges, if you're pretty certain the challenge isn't going to go away, well, then you may as well just address it front up and be good at it.
Well, with that, we thank you again, Ivor.